So it's 3 o'clock and we've got a lot to get through today. So we might even just kick off and just let everybody kind of trickle in as they come if there's some more to still join us. So welcome to the last Prevention Centre webinar of the year. This is going to be a really great one as well. So a big welcome to everybody. Thank you so much for joining this afternoon. My name's Maddie Heenan and I'm a research officer and PhD candidate with the Prevention Centre. And yeah, we're here to listen to our strategic projects. So a big welcome to everybody. A big welcome also to Nadia Masterson, who's attending her first Prevention Centre webinar as our new head of prevention. And she's here to lead the next generation of the Prevention Centre. And this is a great first webinar to join. So it's going to be a combined end of project webinar for our strategic projects and a bit of an emerging leaders network webinar as well. So for those that are unfamiliar with the Prevention Centre's Emerging Leaders Network, it's a network of over 300 early and mid-career researchers, policymakers and practitioners working in the prevention space across the country. So the network provides opportunities for collaboration and for capacity building. Some of the presenters you'll hear from today are part of that network as well. So if you haven't already joined our network, you're welcome to join via the website. So there's a link on there. And yes, today's webinar is a showcase of our strategic projects that have been funded by the Prevention Centre. So last year, the Prevention Centre funded a number of research projects that address strategic priority areas for our policy partners. They focus on a range of different preventive health issues, and today we're going to hear about 5 of those diverse projects covering topics that include tobacco regulation, alcohol consumption, healthy food retail, prevention in early childhood settings, and integrating care for physical and mental health. I'd like to thank the Prevention Centre's funding partners for helping fund this policy relevant research that we're going to be hearing about. And the Prevention Centre would also like to acknowledge Aboriginal and Torres Strait Islander peoples as the first Australians and traditional custodians of the lands where we live, learn and work. And I would like to acknowledge that I'm joining from Bundjalung country today, beautiful lands on the coastal border of Queensland and New South Wales, and pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islander people who may be joining us online today. So as I said earlier, we've got an amazing lineup of speakers and a great showcase of strategic policy relevant research projects. This is a combined webinar with a number of different speakers. So I'm going to introduce them in turn and as we come to each presentation, and then this will be followed by a Q&A session with all presenters at the end. So as we move through the presentations, please put your questions into the Q&A function. You can submit them at any time and I'll moderate the questions to the panel at the end of the presentations. And just a reminder that this session's recorded and we'll be sharing that with registered attendees and network members. So our first speaker is Professor Lennert Veerman, who's going to be presenting on his project Building an Economic Model to Assess Alcohol Interventions. Professor Veerman is a Dutch-trained public health physician with a passion for healthy physical, economic, social and natural environments. He's authored more than 100 peer-reviewed papers on a range of topics in public health, and he has a strong background in epidemiological modelling, burden of disease studies, non-communicable disease control, health impact assessment and cost effectiveness of prevention. So thank you, Lennert. I'll hand over to you.
Thank you, May. So first I need to acknowledge, apart from the traditional custodians to whom I'm speaking from Comber, Maryland, a Deakin colleague. So Deakin Health Economics is the other half of the project. Having said that, let me see. Alcohol still creates a large burden of disease in Australia. So ANHW last year estimated that there were about over 5,000 deaths attributable to this. And alcohol, of course, is medically speaking a hard drug. It's addictive and many people have suffered the consequences. In 2015, it was the 5th highest risk factor in Australia, and it contributes about 4.5% of the total burden of disease in the country. So there are good reasons to take action to reduce that burden. Also because if you're not impressed by health benefits, then there's the economic damage that is done by alcohol. Estimates vary, but there's one from Wetton here that puts it at around 67 billion per year. That's the health damage and the healthcare costs that are associated with that, but also the consequences of violence and injury. Moving forward, policy level action is therefore required. For individuals, it's very difficult to reduce their alcohol consumption or to act on any other behavioral risk factor if the environment is not supportive. So policy level actions can create the healthier living environments. So over the years, the epidemiological evidence has turned against alcohol, if you will. So the assumed protective effect on cardiovascular disease has become smaller in later estimates, and that has trickled through to action being taken. Unfortunately, in Australia, alcohol consumption is going down, but is still very high. And there's growing evidence base as well for interventions that can reduce that harm. And because alcohol is so ubiquitous, even small changes on average can have large population benefits. In order to properly take the best among these policy options that are available, policymakers need evidence based on the best, tailored to those decisions based on the best available evidence. And that's what this project set out to do, is to estimate what the potential health and economic benefits might be of some of these policy interventions. To that end, we created a model. So here is a schematic outline. So from the left to the right, we've got the intervention in gray with intervention costs and changes in the risk factors that lead to a change or reduction in alcohol consumption. That then leads to the model with sections where we've got separate sections for diseases. So some of them are acute, some chronic. The list of health conditions is depicted in the orange box in the middle, going from cardiovascular disease, cancer, cirrhosis, down to lower respiratory infections and intentional injuries. If incidence of a disease goes down, then later in time there are fewer prevalent cases, and in the model, finally that translates to lower levels of mortality. Via disability weights, the prevalence also leads to an improved quality of life at every age, and that then in a life table is amalgamated to estimate the number of health-adjusted life years that you can save, so HALIs. ANHW estimates of the healthcare costs by disease and overall are also incorporated into the model, so we get estimate the healthcare cost savings that there might be, and then those together with the intervention costs, divide that by the number of health-adjusted life years gained, gives you the cost-effectiveness ratio, which is basically the price that you pay on average for one healthy life year. The model runs for 100 years as an open cohort, so we incorporate new generations. They are born into the model, if you will. We assume a 20-year intervention with its effects and costs, and then follow that up, and we applied a 5% discount rate, which is also the rate that the PBAC and others use in Australia. That means that future benefits, as you can see in the graph, are discounted heavily, so count for much less in net present value, if you will. So 25 years into the future, you've got only a quarter of your value left. So not good for prevention, and that's what we assumed in this intervention, in this modeling exercise. The policymakers in the advisory board were interested mainly in 5 interventions, and I'll present the preliminary results in the coming slides. So don't take these to be the final estimates, but they give an indication of where things are going. Restrictions on alcohol advertising, reduced trading hours for premises and late nights, so lockout laws, restrictions to limit alcohol outlet density, minimum unit price legislation, and a volumetric alcohol tax. So restrictions on alcohol advertising, one of the main drivers of consumption. On the right-hand side, so on the top left, there's the intervention. So this is a complete ban of alcohol advertising across all media in Australia. So that's a fairly radical intervention. Population impacted, because the study that we based this on was only based on adults aged 18 to 45 years. That's what we modeled. So this underestimates the true impacts, but does count the full cost. So with that caveat, to the right is what we call a cost effectiveness plane. If you go further to the right, your health benefits are greater, so your HALIs. If you go up, your costs go up, so that's not so good. So you want your interventions to be in the lower right quadrant, because there you're getting a health benefit and you're saving money. So the intervention costs are outweighed by cost savings of having to treat fewer cases of disease. Now, of course, in this intervention, this looks very favorable. There's a good chance that here it's in the lower right quadrant. So you get a health benefit of up to 200,000 healthy life years. And you might then get a net health cost benefit as well. The dotted diagonal line through there is $50,000 per healthy life year. And any dots, so every dot is one iteration of the model with uncertainty. Every dot that is on the right-hand side and below is good. On the left-hand side, well, there it becomes more expensive, so you might not want to do that. The blue here is discounted, and that's much less than the undiscounted in terms of health benefits. The shape also changes, and that's because you discount the years of additional life in which people live longer and then have more healthcare costs. So it's a bit of a funny effect that you get there. The table is there, but just go to the bottom to the cost effectiveness ratio, which suggests that on average, you'd expect to pay around $4,000 for one healthy life year. But it could be that you're actually saving money, or it could be up to 45,000, more or less, taking the 95% uncertainty boundaries. That's what that means. So in all, this looks very favorable. Reduced trading hours. So that's just reducing by 2 hours trading hours for in metropolitan areas across Australia. So this is only a small intervention, relatively speaking, so the health gains are much smaller. The evidence is rather uncertain. So there's, and the uncertainty translates to the sliver being to the left-hand side here of the 0 in the graph. It does not seem very likely, based on the nature of the intervention, that you'd really get a health damage. So I have to take that with a grain of salt. There's also a very good chance that, again, this is an intervention that saves money and gives you a health benefit. So on average, $1,700 for a healthy life year with large uncertainty. Restrictions to limit alcohol outlet density. This was modeled for New South Wales and for Victoria because we had the best data for those. Here, the scenario was that no new or that no additional alcohol outlets would be permitted in those states, which means that gradually there would be a reduction in the availability of alcohol in the streets. Health gain, because this is only on New South Wales, relatively modest, but this is certain to be in the dominant area, so giving both a health benefit and an economic benefit. Similarly, for the same intervention in Victoria, the uncertainty is slightly larger there, but basically that's the same pattern. Minimum unit pricing is unequivocally a very favorable intervention. So in the graph, you can see that the dots in blue, at least the discounted ones, are all in that lower right quadrant where we most want them. So this is a HALI gain of around 200,000 and cost effectiveness ratio that is almost certain to be dominant. Likewise, the other tax-related intervention, volumetric alcohol tax, as previous research has also suggested, is almost certain to be a winner. Slightly larger impact than the modeled minimum unit pricing here, and again in the favorable quadrant. So if we put that all together, please ignore the last column in this table because that's an error. table does not seem to, or the dots don't seem to show, at least on my screen, so I apologize for that. If we go to the table, the middle column there is cost effective. So that's the chance based on this analysis that an intervention would be below $50,000 per healthy life year. So for the first three, including the tax interventions, that's 100%. And then the others are very favorable as well. The stricter line as well. If you want it to be cost saving, then the first three meet that criterion. Liquor density in Victoria, most likely as well. And the advertising ban and trading restrictions have a fairly good chance of actually being cost saving in economic terms. That's the end of that. Thank you.
Thanks so much, Lennert. That's really amazing research. We know that those policy interventions are WHO best buys, but to see, I guess, like the localized evidence is really valuable, I think, for our policymakers. So really amazing research there. So next we're going to hear from Professor Sarah Durkin and Dr. Ashleigh Haynes on their project Public Communication about Tobacco Control Regulation. Professor Durkin is Acting Director of the Centre for Behavioural Research in Cancer Council Victoria and an Honorary Professorial Fellow in the Melbourne School of Psychological Sciences at the University of Melbourne. Over 2 decades, Professor Durkin has established a research program which has been instrumental in shaping tobacco control and other cancer prevention campaigns in Australia, as well as internationally. Her research is highly applied and has generated critical evidence that has guided public health organisations to design, broadcast and evaluate tobacco control campaigns in the most efficient and effective manner. Dr. Haynes is the David Hill Research Fellow at the Centre for Behavioural Research in Cancer Council Victoria and an Honorary Research Fellow in the Melbourne School of Psychological Sciences at University of Melbourne, using a range of methods including observational studies, content analyses, population surveys and experiments. Her research has investigated the nature and impact of food environments and unhealthy industry marketing relating to diet and obesity. And she's more recently expanded this area into sun protection, alcohol and tobacco control. She's collaborated with policy advocates, decision makers and practitioners, and her work's been used in policy advocacy and health promotion practice related to alcohol labelling, food and drink marketing, public health mass media campaigns, and school food environments, restaurant menu labelling, and action on portion sizes. So I'll pass over to Sarah and Ashleigh to tell us more about their project. And just a reminder that everybody, you can populate questions in the Q&A function at any time, and we'll get to those at the end. So thanks, Ashleigh and Sarah.
Thanks very much, Maddie. Good afternoon, everyone. I'm pleased to present the findings from our project today. As Maddie introduced, I'm joined today by Professor Sarah Durkin, but I also want to begin by giving a shout out to the rest of the project team at Cancer Council Victoria, and it's to them to whom credit for this project is really due. Tegan Nuss, Claudia Gascoigne, Dr. Emily Brennan as the project lead, and Professor Melanie Wakefield. The National Tobacco Strategy proposes several actions to reduce the attractiveness and addictiveness of smoking by regulating the design and manufacture of tobacco products. For example, a ban on the use of menthol and other flavours or flavour capsules or crush balls in the filter was proposed last year. As we move toward increasing regulations on tobacco products, it will be important to know how to maximise their public health impact and how to minimise unintended consequences. So we undertook 2 consecutive studies to examine whether public communication messages could increase intentions to quit smoking, reduce harm misperceptions, and promote accurate understanding about the reasons for such bans. In both studies, we examined 3 product bans: a ban on menthol and flavoured crush ball cigarettes, as announced last year, and 2 hypothetical scenarios for Australia. The first, a ban on filter ventilation, such that cigarettes could no longer contain tiny holes around the filter that allow air to mix with the smoke to produce a lighter feeling and more palatable smoke. And the second, a ban on regular nicotine content, so that only new, very low nicotine tobacco products would be available. New Zealand will be implementing this ban in 2025, whereas a ban on filter ventilation hasn't been proposed in any other jurisdictions. Participants took part in one study arm and were allocated based on the products that they were currently smoking. Study 1 was an online cross-sectional survey of 934 adults who smoke and was conducted to inform the messages to be tested in Study 2. Participants were presented with a brief description of one of 3 product bans, and they were asked what they thought they'd do in response. We found that across the study arms, between 13 and 26% said that they would try to quit in response to the ban. And the products that participants most commonly reported they would use if the bans were implemented are shown in blue, and these products were then specifically addressed in the messages we tested in Study 2. Study 2 was an online experiment among 1,514 people who smoke, and it aimed to investigate which messages best encourage people to try to quit rather than to use an available product, and whether these messages could also reduce harm misperceptions about available products and promote accurate perceptions about the rationales for the bans. So again, we had 3 arms of the study for the 3 product bans, and participants in each arm were randomly allocated to one of 3 message conditions. As shown in the figure here, the message conditions were additive, with the level of detail provided in the messages increasing across conditions. All messages introduced the ban and provided the rationale, as well as explicit encouragement to quit. And this is because we expected that any public messaging would include these elements as a minimum. Conditions B and C then contained additional information about the harmfulness of tobacco and e-cigarette products still available for sale following the ban. For example, tobacco products without menthol and without flavoured crush balls are just as important as just as harmful as those containing menthol and those with flavoured crush balls. And finally, only condition C contained further information about the negative attributes of the available products, such as highlighting the true taste and harshness of the toxic smoke from cigarettes without menthol or flavoured crush balls. Thanks for listening. I'll pass back to Maddie now.
Thanks so much, Ashleigh. That just really highlights how important communication campaigns are when we're introducing new policies and legislation. So I think, yeah, it's really fantastic to see that work, and looking forward to some questions about that next. So up next, we are hearing from Dr. Shaan, Naughton and Sherridan Cluff on their project co-creating tools to support the transformation of the food retail environment. Dr. Shaan Naughton is a research fellow at the Global Centre for Preventive Health and Nutrition at Deakin University, where she manages and performs research within the Centre of Research Excellence at the CRE in Food Retail Environments for Health, or REFRESH. Prior to completing her PhD in nutritional biochemistry, she was awarded a Bachelor of Science Nutrition with honours in biochemistry and a Master of Dietetics. Through her research, Dr. Naughton aims to combine her previous training in commercial cookery and her public health nutrition skills to create innovative solutions to improve the health of retail food environments. An additional area of focus is the dissemination and translation of knowledge to meet the specific needs of policy and practice partners. Sherridan Cluff is a senior dietitian and nutritionist at Health and Wellbeing Queensland and has a background in exercise science and dietetics. Her work focuses on the development, implementation and evaluation of programs and policies to improve community wellbeing. Sherridan is particularly passionate about food environments and how physical, social and sociocultural factors can influence people's food and beverage choices. She recognises the real challenges in maintaining healthy eating habits, especially amidst the time constraints, limited resources, social dynamics often facing individuals, and is committed to reducing these barriers. Sherridan is the project lead at Health and Wellbeing Queensland's, is the project lead on Health and Wellbeing Queensland's A Better Choice initiative, which focuses on improving the availability and promotion of healthier food and drinks in public settings. And we're going to hear a little bit more about that initiative now. Over to you, Sherridan and Shaan.
Thanks, Maddie. To begin, I'd just like to acknowledge that I'm presenting on behalf of the original co-leads of this project, so Dr. Tara Bulson-Robinson and Dr. Miranda Blake.
Hi everyone. So to begin with, I just wanted to set the scene about how the original partnership between Durkin and Health and Wellbeing Queensland came to be. So for context, Health and Wellbeing Queensland is an independent statutory body within the health portfolio of the Queensland Government. Our remit is to improve the health and wellbeing of the Queensland population and reduce health inequities with initial focus on reducing the risk factors that drive the chronic disease burden, such as poor nutrition, physical inactivity, and obesity. So in recognising the role of food environments, in particular on the nutritional health of the population, Health and Wellbeing Queensland is driving the A Better Choice initiative, which is a policy approach to increasing the availability and promotion of healthier food and drinks in the places where Queenslanders spend their time. So similar to a lot of other food and drink supply frameworks and policies that exist across Australia, A Better Choice uses the Australian Guide to Healthy Eating to classify food and drinks according to their nutritional value in a traffic light system and provides targets around the types and amounts of these food and drinks that should be available in public settings. So we have a number of setting-specific strategies that we've developed and released to guide the availability, display and promotion of food and drinks in particular settings. And the first of these was a strategy for healthcare facilities. So this strategy was first developed and implemented by the Department of Health here in Queensland in 2007 and was mandated in 2020 with the establishment of a health service directive for hospital and health settings. Health and Wellbeing Queensland then took on the ownership of the A Better Choice strategy in 2021 and reviewed and refreshed its content. And since we've been supporting hospital and health services to implement the strategies in their retail outlets and vending machines and through their promotion and advertising. We do this primarily through access to a centralised project officer within one of the health services and through funding of Food Checker, which a lot of you will be familiar with. It's an online food and drink classification tool delivered by Nutrition Australia Victoria with funding from the Victorian Department of Health. It's particularly important to note in Queensland that one of our biggest barriers for implementation of A Better Choice is the lack of dedicated capacity and capability within the health services for implementing A Better Choice. So unlike other states, Queensland doesn't have dedicated health promotion staff sitting within each health service or within each local local government area. So implementation of prevention initiatives like A Better Choice does become the responsibility of internal hospital staff. So in the case of A Better Choice, this could be a dietitian, food service staff, retail managers or operational staff who are taking on this role as on top of their business as usual. And more often than not, they're facing barriers with the retailers who just really don't want to engage. So given this limited capacity, obviously a huge focus for Health and Wellbeing Queensland, and one of our priorities for A Better Choice is building resources that fills a gap in the capacity and helps people to implement A Better Choice. So I initially approached Durkin, given all of their experience in this area, for their advice and support on implementation approaches and resources that might work for the health audience. And this is where the opportunity to test some implementation support tools as an intervention actually arose. As a policymaker and health practitioner and an organisation, this was particularly appealing to us as it provided immediate benefit to our health services in the implementation of A Better Choice in terms of providing them tools and resources. But it also offered us an opportunity to build evidence that actually supports further tool development and helps us to engage with further settings as we start to expand A Better Choice. I'll hand over to Shaan now, who will talk a bit more about what the project is we're actually doing.
So before Sherridan reached out to our team, we'd been exploring using co-creation approaches, such as the example here from the work of our larger research group, to create implementation support tools. Though up until this point, our wider team had generally been using co-creation approaches in designing studies. So why did we use co-creation? A lot of our recent work in this space has been led by Carmen Vargas, and the recent definition of co-creation is from her work. The stakeholders or end users in this context are health promotion practitioners, retailers, or any other stakeholder involved in implementing healthy food retail. We believe that co-creating the tools directly with end users would ensure that they're practical, acceptable and effective at creating change. So the idea of using co-creation to develop retailer support tools specific to retailers in Australian settings was addressing a gap identified in a separate project, which was led by Tara, and the idea was formed. So briefly, and this is quite a detailed study, but so this approach led to a co-created retailer toolkit. This was developed by the Nourish Network Healthy Food Retail Resources Action Team for Victorian settings. So when Sherridan approached the team, we recognised that we could take this Victorian specific toolkit and it to be adapted to a Queensland setting, which Health and Wellbeing Queensland did. So the co-creation process and the value that was co-created in making this toolkit is also being explored through a qualitative study that's a component of this larger study, though I won't be focusing on that today. So this adapted retailer toolkit was paired with practitioner training, which was informed by the systems thinking approach for retail transformation, or the Start Map project. So you can see the paper for that up on the right-hand side there. So the Start Map was developed to combine systems thinking with existing health promotion concepts found to be used in similar settings where healthy food retail policy is being implemented. So in a nutshell, the CREATE study is a 6-month pilot RCT in 5 Queensland hospital and health service settings. So that is covering 14 different hospitals, all of which are in the southern Queensland area. So this study was designed as a pilot hybrid implementation and effectiveness trial to perform power calculations for a full-size randomised control trial. So briefly, we are doing surveys with health promotion practitioners and retailers at baseline and at 6 months, and also doing environmental audits to look at the change to the health of the food available in the retail outlets. So noting that this study is still currently being conducted, I won't be presenting any of our specific results, though more so focusing on what we've learnt so far. So in terms of policy relevant findings, the current ethics and governance processes in healthcare settings really limits the ability to perform rapid applied research, basically due to the current processes being designed for clinical research trial type studies, and different hospitals and health services have different processes to navigate governance. Additionally, being external to the organisations and also with the research team being located in Victoria, it was extra difficult to navigate a lot of these internal processes. That said, once we had all of our approvals in place, the hospital and health service employees that we were interacting with, the various sites were incredibly supportive of both of our study and also of the Better Choice strategy. So pass back to Sherridan for the Health and Wellbeing Queensland perspective.
So to share a few findings from a policy partner perspective, there's been some really interesting things to come out even of the initial stages of the study and in the recruitment. So to second what Shaan said, it is quite obvious to us now how different every facility can be in its processes, from engaging in ethics and approvals through to actually recruiting and getting consent from the participants. What seemed to work in one health service didn't work in another, and what works in one facility within a health service doesn't work in another facility in the same health service. We've learned a lot about processes, which is really great for us as we consider further research in healthcare for a better choice and our evaluation of the program as a whole. But it's also really important for us to know this as we think to expand a better choice into other settings, because if it's this different in healthcare, it's likely to be even more different in other settings. So we need to incorporate those timeframes into our planning. I also wanted to touch briefly on what I mentioned earlier in the presentation in the barrier that is the low capacity of the health practitioners. It's a barrier to the implementation of a better choice, but it continued to be a barrier to them actually engaging in this project. I think there's a number of additional facilities that we could have got consented to the project if capacity wasn't an issue. A lot of them would have loved to take part, but they just simply didn't have the time. From a policy and program perspective, I think we can take this learning and put more emphasis on actually capacity building within HHSs so that they do have time for opportunities like this. And potentially that even means the consideration of incentives that allows them time to participate in a project like this so that they can get the leadership buy-in and to come on board. Going back to the process for engagement, another thing that was really interesting to us is just how much particular stakeholders within hospital and health services had actually heard of the A Better Choice initiative. This was surprising to us because we thought that it was quite well known, but as soon as we started approaching research and ethics, there was an assumption on their end that we were looking for clinical data and patient-centered data, but that's not what A Better Choice is about. It's about the environment. And similarly, when we were looking for principal investigators to help us with recruitment with the study, there was a lot of time that was spent from Shaan's team and Health and Wellbeing Queensland to build communication materials and talk about what A Better Choice is and how this study relates. So it was eye-opening to us in terms of how much more we can do in actually promoting A Better Choice across the system so that future opportunities can be more streamlined. Finally, I just wanted to touch again on the retailers and their lack of engagement in A Better Choice. Again, that is coming across in this study, and then really not seeing the provision of healthy food and drink as a priority or their responsibility. And they're really pushing back on health practitioners in terms of offering these things. We've really had to prompt them to consent in the study because they don't see it as a priority. And again, I think this is a learning for us, and we can take that and increase opportunities for engagement with retailers and suppliers. So all of the burden isn't sitting on our health practitioners. And I think one of the ways that we can do this is actually to strengthen the contractual obligations for this group. And we've done that recently where we revised the Health Service Directive, and we've actually put the requirement for ABC to be in contracts with suppliers and retailers to help to build that awareness and drive that change.
So in terms of what next, obviously we're going to complete the pilot RCT, and then we're going to further explore how co-designed implementation support tools can be used in healthy food retail, including potentially the fully powered RCT. So this will be part of our newly funded Centre of Research Excellence in Food Retail Environments for Health, or Next Generation. So refreshing will begin early next year. We're also currently exploring other opportunities to partner with Health and Wellbeing Queensland and Sherridan's team on a lot of projects where we've got overlapping interests. So I'd just like to finish, obviously this is quite a large study, so it's been a bit of a team effort. So I'd like to thank all of our partners involved in all the different parts of the study and the team. Back to you, Maddie.
Thanks, Shaan and Sherridan. So great to see the collaboration that you guys have built together and see you working jointly on a really cool project. You've got a lot of lessons already, even though there's no, I guess, like research findings to date as yet. There still is. Actually, you've just presented a whole heap, but I'm really looking forward to seeing what continues to come out of this work. So thank you for that. So next up, we just flick through. We've got Associate Professor Serene Yoong and Dr. Amy Anderson presenting on their project, Learning Health Systems Approaches to Optimise Implementation of Prevention Programs. So Associate Professor Serene Yoong's a Deputy Director of the National Centre for Implementation Science and Associate Director of the Global Centre for Preventive Health and Nutrition at Deakin University. She has expertise in undertaking large-scale implementation trials to reduce risk factors for chronic diseases in community settings, including childcare centres and schools. She has also produced seminal work related to implementation methods, including providing guidance for undertaking implementation trials, the development of measures for implementation determinants and pilot hybrid trials. In recognition of her leadership, she was awarded an Australian Institute of Policy and Science Tall Poppy Award in 2018 and Bupa Early Career Research Award. Dr. Amy Anderson is a senior research officer in the fields of health behaviour and population health. Dr. Anderson's research has mainly focused on modifiable health risk factors to modify services and inform policy, such as through her work with the Australian Longitudinal Study on Women's Health. She's a growing interest in implementation science, leading on from previous project management experience on an NHMRC partnership project aiming to implement clinical guidelines within antenatal services to improve provision of care related to maternal alcohol use. Dr. Anderson has used quantitative, qualitative and mixed methods research with a heavy utilisation of both cross-sectional and longitudinal survey designs. Dr. Anderson currently works at University of Newcastle in partnership with Hunter New England Population Health and Deakin University, investigating barriers to implementation of healthy eating and physical activity practices in the childcare sector. And we're going to hear a little bit more about that from Serene and Amy now. So over to you both.
Thank you, Maddie. Good afternoon, everyone. I'd just like to acknowledge that I'm on Wurundjeri land and Amy's calling in from Awabakal land. I want to acknowledge our partners on this work as well, in particular Hunter New England Population Health, as well as the New South Wales Centre for Population Health. So as Maddie said, I'm Serene. I'll be presenting today with Amy on our experience developing and piloting a learning health systems approach to optimise implementation of nutrition and physical activity programs in childcare centres. So childcare centres, they're a recommended setting for the delivery of population-based prevention programs to improve child diet and physical activity. They provide broad reach to young children. Over 80% of 4 to 5-year-olds are in care. We know there are a range of evidence-based prevention programs that can be delivered in this setting, and almost all states in Australia have this as a priority setting for health promotion support and for prevention. However, we also know that many of these programs are not routinely implemented. So our Cochrane systematic review that we undertook to look at how to support implementation into childcare centres identified, unfortunately, limited impact of a number of implementation strategies to support this process. And we thought one important reason for that is that health promotion programs or implementation strategies are often designed to target barriers to implementation that are assessed only at the conception of a program. So we might speak to stakeholders or end users about what their barriers are prior to designing a program. But by the time you go and implement something, things change and your barriers change over time. But a lot of programs don't take into account how the context evolves and the barriers evolves. And we hypothesize, I guess, that if you tailor your support to target those barriers as they come up, we might be able to provide better support. And so I guess that's kind of the premise of this this study that we'll be speaking to. And so what we sought to do really was to collect data in an ongoing way about barriers to implementation. We sought to provide this data back to health promotion teams to support childcare centres, and then we sought to support health promotion teams to interpret the data that we provided to address barriers as they arise. I too then froed a little bit about whether to spend 3 minutes talking about what learning health systems is, because that's kind of part of the title. It has I guess quite a lofty definition, but I might just kind of draw your attention to this framework by kind of Mina and colleagues here. They describe sort of 3 pillars three sections to a learning health system approach. It covers the kind of pillars in terms of making it happen, the process, and then the outcomes that you might expect. So in the blue there, which is a little bit little, is the process. And that's what we'll be focusing on. Essentially, you can see it's an iterative cycle where you use data from practice to inform generate knowledge, and this knowledge is then used to inform practice, which then kind of goes back in. So a bit of an iterative cycle to address a problem or a challenge within the health service. So if all of this is a little bit hard to follow, don't worry, I'll try and describe what we did in 3 nice linear arrows, and Amy will show you what we actually mean. So hopefully that kind of reinforces what we've done. So one of the challenges with doing this in, I guess, public health and prevention is we don't have much routine data to draw on. And so the first really big thing that we did was to develop our continuous data collection system with childcare centres. So we established a panel with centres that we had previously undertaken research with. So we started with about 1,000 childcare centres. We worked with the New South Wales Centre for Population Health in Hunter, New England, as well as the other chief investigators on the ground to identify priority and evidence-based physical activity and nutrition programs for them. And then, as you know, surveys can get very long. We tried very hard to develop a brief assessment tool for barriers. And then we worked with the health promotion teams within New South Wales to, I guess, try and identify how to feedback data. Initially, we had proposed, I guess, meetings to present that with rapid data analysis back, but I think we rapidly realized that meetings probably wasn't the best way to provide real-time data. And so we settled on a dashboard, which would present the data in real time, but then also provide some level of interpretation about when a barrier has changed. And then the last thing is to actually collect the data and then pilot the system and see whether it's actually useful. So I think this is the part where I hand over to Amy to show you the dashboard.
Okay, thank you, Serene.
Mm.
Okay. So as Serene mentioned, so we've created an assessment monitoring system for the barriers. So we created a data dashboard using Power BI, and that's linked directly to our barriers assessment tool in the Red Cap program. And this allows us to monitor data in real time. So now I'd like to give you, I guess, a preview of what our dashboard is and look at its functionality. So just have to share my screen and hopefully it all goes smoothly. So hopefully you can all see the dashboard. Yeah. So this first page just, I guess, keeps track of our barrier surveys and how many childcare services have completed. So we've had over 700 completions to date. Data collection is still ongoing at the moment. Our next few pages are just based on our demographics of the services who are filling them out. We did oversample in New South Wales, just availability of services for the panel. We have our states, our remoteness indicators, and also our socioeconomic indicators. We also have measures of cultural diversity in terms of children from linguistically and culturally diverse backgrounds. So in order to, I guess, track the barriers over time, the barriers to implementation, we also had to track implementation over time. So we focused on 2 main evidence-based practices, one on healthy eating and one on physical activity. And as you can see by this graph, the proportion of services who are implementing these 2 priority practices has remained relatively stable over the course of this study. Our filters on the right-hand side of our dashboard allow us to interact with this data. So, for example, we might only be interested in looking at what's happening in major cities, and it will adjust accordingly. So users of the dashboard can essentially decide, I guess, what filters they would find most useful when interacting with the data and how they'd like to filter that. So in terms of barriers for our 2 practices, we narrowed it down to the top 5 barriers for each healthy eating and physical activity practice. So you can see there's a different page for each, just being wary of time, I will not be going through all the barriers. Just focus on a couple just to give you an idea of what the dashboard does. So to track barriers over time, we've employed control charts. So these charts are usually used for quality control purposes, and they allow us to set rules, which are just under that bottom chart there, which will flag when an unexpected change has occurred, or variation we weren't really expecting has occurred. So in this graph, for example, you can see, there's not much unexpected change. However, on the next graph, one of our rules was violated, so our color indicators have popped up. Now, the reason this is important is, I guess, users say if a state health system or health department has introduced some implementation support with some staff training around healthy eating, you may see that staff skills and staff knowledge increase. They have less of a barrier, so their scores increase. Or if they withdraw support, withdraw implementation support over time, and a rule is violated, that might just essentially it's a prompt for the service to go and find out what's actually going on with these centers. Had something occurred? Was there a change in support or something else? So that's the first. This kind of just allows us to monitor the change over time and allows us to address as barriers arise and they change over time. So the bottom graph actually displays the monthly aggregate barrier scores, and you can see anything under a 6, these red dots, is considered a barrier, with lower scores suggesting stronger barriers. There's also, we have our trend line, so it's relatively stable at the moment. The interesting thing with this, and I guess is, say a health promotion team who's working with a number of childcare centers in their area, they might be looking at this and saying, hey, who are these low barrier scores? So you can actually, they can focus on and identify the services that may be having some difficulty with say in this area, the staff knowledge, and then they could investigate and provide extra support for the services accordingly. So I guess this is just a helpful way for them to actually track what's happening and then identify where support may be needed. So additionally, I guess you may want to look at, we have our filters again for our barrier scores. So if we only want to examine, say, those services who are not implementing, if there's a slight change, you can see that graph drop just a bit. Or you might want to focus alternatively on those who are implementing the practice. So you can see they're much less likely, I guess, to have barriers. So I will now just pass back to Serene. There may just be a moment of change while I stop sharing and we get the presentation back up. So hold on one moment, please.
Thanks, Amy. And so I guess that's really a prototype of how we're hoping to present the information back to people that might use it. The next step is to really go back to our partners on the ground and to identify any others who may find information like that useful. As you can see, we did a national survey with an oversampling of New South Wales services. So there are childcare centres represented from every state. So this is, I guess, really a starting point in terms of trying to operationalize how you would use data in prevention to optimize health service delivery. It's only as good as the routine data collection systems that are in place, and whether people will use and access and find it useful to address some of the challenges. I mean, one of the key challenges, I guess, that Sherridan brought up around capacity may be a consideration here in terms of using systems like this. But I think we wanted to try really hard to demonstrate how data could be used to inform practice and how practice can then inform yeah, what might be important to collect. And so yeah, so that's all from us. I will hand it back to you, Maddie. Oh, sorry, I think there's one more slides. Sorry, acknowledging the project team and our partners. Thank you.
Thanks so much, Amy and Serene. It's really cool to see such like a different platform to be able to deliver that information back to the stakeholders. So that have to ask a couple of more questions about that shortly. But I'll pass over to Dr. Caitlin Fehily, who is going to be presenting on the project Integrating Care for Physical and Mental Health. So this is our last project for the webinar. Caitlin is a postdoctoral researcher at the University of Newcastle, currently working within the School of Psychology at the University of Newcastle. Her research interests include addressing the inequitable chronic disease burden experienced by people with a mental health condition. Caitlin is involved in a number of research projects across local and national community mental health services, community managed organisations, telephone-based support services and other health service settings. Her primary role is the project manager for a large cluster RCT with 12 government community mental health services across 3 local health districts. Caitlin was awarded the 2022 Eileen Plant Medal from the Public Health Association of Australia for making a significant contribution to the field of population health. So I'll pass over to Caitlin to hear about this really cool project. Thanks, Caitlin.
Thanks so much, Maddie, and good afternoon, everyone. I'm joining today from Awabakal country, and I've really enjoyed listening to all the other presenters today, and I'm excited to share with you some of the findings from a qualitative study that we've undertaken to explore perspectives of different stakeholders about a project that was integrating physical health care into community mental health services. And although it's just me presenting today, I'd just like to acknowledge all the team members who have contributed to this research, as well as the community mental health services who have partnered with us, and of course the Prevention Centre for funding this study. So a little bit about why we're doing this research. So some of you may already be aware that people with a mental health condition experience a lower life expectancy than the general population. And that's largely due to physical health conditions and a higher likelihood of engaging in risky lifestyle behaviours such as smoking, poor nutrition, harmful levels of alcohol consumption, and not getting enough physical activity. And for this reason, it's increasingly recognised that there needs to be improved effort to offer evidence-based preventive care to support people to make some positive lifestyle changes. And that includes mental health services providing that care alongside their routine mental health treatment. And this can be as simple as evidence-based models like the one down the bottom of the screen there. That's recommended by some policies and guidelines that simply asking clients about their risk behaviours, providing some advice to change, and then offering referrals to other support services. And so some of the past research by our team, that's led by Jenny Bowman, has found that people living with a mental health condition do want to make changes to lifestyle behaviours and would like to receive support from their mental health service to do that. However, despite this and the policies and guidelines, we found that preventive care isn't always provided in mental health services, or it might not be provided systematically or routinely to all clients. And there's a number of reasons why that's the case. So although mental health clinicians might and do recognise that preventive care is important, they might not always have the confidence to be able to address these risks, or there's simply sometimes inadequate time to be providing preventive care during routine mental health consultations. So this leads to a trial that our team conducted to try to address these barriers. This is called the Health Snap trial, and it aims to build the capacity of community mental health services to provide preventive care in line with clinical practice guidelines and policies. And the project builds on a pilot trial that we conducted a few years ago that was also funded by the Prevention Centre. So really briefly, just to give some context for the broader trial, So HealthSnap is a cluster randomised controlled trial that involves 12 different community mental health services across a few local health districts in New South Wales. And half of those were randomised to receive a 9-month intervention. And so that intervention involved implementing a new model or a new way of providing preventive care. So firstly, a new role was embedded in the service, so a healthy choices coach, and the coach had the dedicated role of providing clients an extra appointment that was just focused on healthy lifestyle. So really the coaches help to kickstart preventive care by conducting a more comprehensive assessment of clients' current lifestyle behaviours, seeing what goals they might like to make for change, and offering referrals as well. And the coach then ensured this information, such as the client's goals that they wanted to set, was integrated into the existing electronic records, such as the client's care plan. So that then meant that it was visible to the client's usual or regular mental health clinician, who then had the responsibility of continuing to provide some ongoing support and follow-up for that client during their routine mental health consults. And just to very briefly mention that to help implement this new initiative, there were a number of implementation strategies that were co-developed with the services and delivered across the 9-month intervention period. So this included, for example, things like training for clinicians, so training sessions such as in motivational interviewing skills, as well as written or electronic resources. So with the support from the Prevention Centre, we conducted a qualitative study alongside the HealthSnap trial to inform our understanding of how the project was being implemented and how it was being received by the services. So this included some focus groups that we did about during the midpoint of the intervention, so partway through, as well as some interviews at the end of the intervention with managers, mental health clinicians, and the Healthy Choices coaches as well. I'll just also acknowledge that we are also undertaking some interviews with consumers too, but these are still underway. So I'll just share now some of our key kind of preliminary findings that are coming through from this data, but just to I guess note that the final interpretation of these results is really dependent on us knowing the outcome of the trial, so whether or not the intervention was effective or not, and we don't know the answer to that question yet, so the analysis is still underway. So I'm just sharing some key messages that are coming through from just the qualitative data for now. So to start, participants really viewed the model of care to be acceptable and described it largely as being a success. And so, for example, on the top left of the screen there, you can see one of the participants talking about how the project was able to normalise providing preventive care as part of routine mental health practice, which really was the goal of this project. People also spoke really positively about having the new role of the Healthy Choices coach. So saying that it was perceived that that may have been refreshing for some clients to have someone new to talk to just about their physical health. And that it was also great for clinicians. So clinicians were reflecting on how they could see and learn from the coaches, and that demonstrated that providing preventive care was something that was doable and was being really well received by their clients. And lastly, participants also reflected on some of the positive outcomes that they could see their clients achieving. So things like cutting down on caffeine and soft drink. But like I'm sure any study, there were some challenges and barriers noted. So things like external or contextual factors like COVID and high staff turnover. There are also some project-related factors too. So despite best efforts, some clinicians mentioned that they may not have been aware of all of the training or all of the resources. And although the aim of the project was that all clients would be offered that extra appointment with the Healthy Choices coach, and that all mental health clinicians would then be involved afterwards in providing some follow-up care and support. Both those two elements were tricky to implement in practice, and many participants noted that that may not have always happened, and that might be due to factors like time and even just clinician memory to be conducting that follow-up with clients. So participants also shared some recommendations to improve the impact of our intervention. Some of these were identified partway through because, as I mentioned, we had the focus groups that were at the midpoint of the intervention. And so we conducted some rapid analysis to help us identify the key recommendations coming from that and then implement those in the second half of the intervention. And so this is why these have got big ticks next to them, because there were some changes that were made. So for example, boosting our leadership strategy. So having leaders find more ways to be communicating more regularly with their teams about the project. So in different existing meetings and forums. And then at the bottom of the slide here at the second half, other things that, some examples of some things that were identified after the intervention. So just draw attention to the one in the bottom middle there. This was really interesting because most participants did recommend having more opportunity for the coach to be following up with clients, so more than just a one-off appointment. And that may have been linked to the note on the previous slide that clinicians were finding it challenging to be providing the ongoing care and follow-up themselves. And that really was the hope of this project, that we could be integrating preventive care into ongoing practice. So it'll be interesting for us to unpack that recommendation a little bit more as we continue to interpret the findings. So in terms of our next steps, from the views shared in the qualitative research, it seems that the intervention was viewed as acceptable and had positive impacts for clients and clinicians. But it also highlighted us what didn't work so well, which led to some changes in our intervention period, but could possibly also inform future initiatives aiming to improve physical health care in mental health settings as well. So our next step is to finalise the main outcomes analysis for the trial, and then these qualitative results can be interpreted alongside that to help us understand a little bit more about how and why the intervention may or may not have been effective. And so we're planning a few publications related to this project that we're hoping to disseminate next year. And that's it from me. Thank you so much, everyone.
Thanks, Caitlin. Unfortunately, when we have so many amazing presentations, we start to run out of time for Q&A at the end. So we've just got a short 15 minutes left. But I'll start with you, Caitlin. I was wondering, with your stakeholder groups, did you see the same type of positive responses across the clinicians and the coaches and the consumers, or was there sort of more enthusiasm from one group than another?
That's a really good question, Maddie. So I think there were largely the same findings or views kind of shared. There were some differences. So particularly, for example, within the more rural sites that were involved in the project, I think that was where clinicians in particular might have been feeling more time pressures or more staffing pressures as well. But the views around the acceptability and, I guess, positive attitudes towards the project were pretty consistent across those different sites. Yeah.
That's incredible. I've also got a question for Lennert. Go back to your model on the different alcohol policies. I was wondering about the advertising ban. It showed that, you know, the cost savings were a bit lower compared to, say, the density measures. And I was wondering if you had any sort of thoughts as to why that might be. Is that because of that smaller age cohort that you mentioned, or is that because of implementation costs with trying to implement a whole ban on advertising?
Well, we'll have to have another look at the costing there. So what's included? So one thing is that some people lose money advertising income, etc. So that to some extent is in there. But you're right that the if you go up to age 45, then you've got most of the acute alcohol consequences for younger people. So injury, etc., is important there, and the alcohol dependency. But then the older people, you get the chronic diseases. But by the time the model reaches that, the discounting has reduced those benefits. So I think the picture is a little bit unfair for this intervention on our current analysis.
Thank you. Question for Shaan and Sherridan. I was wondering if you had partnered before this project, or if this project was really kind of what initiated your partnership, and if you could reflect on the value in undertaking a co-design approach, and what you might recommend for others who are looking to do something similar.
I'm happy to go first. This was the first study that we've worked on together, and I think it was purely luck that Sherridan reached out to our team just before the applications for this funding round opened. So it was a real quick rush to get sort of a project worked up. In regards to the co-design process, so that was actually done. I didn't have all the time to include it, so that was done through the Nourish Network. So that was sort of before Sherridan and her team came on board. So that was co-designed with a group of people who had experience in implementing healthy food retail policies, retailers, and also people from the Healthy Eating Advisory Service who, as most people probably know, do a lot of assistance with implementing and helping people actually get those policies in place. So we are doing an evaluation of the co-design process, which we're hopefully having finished the next couple of weeks.
Yes, you mentioned that. That's great. Sherridan, did you have anything else to add there?
Just to say that I think the real benefit from what Shaan and her team are doing in co-design to us as policy implementers is that it's taking into account the people that our initiative is just designed for, and hopefully that means it's going to increase its impact. So yeah, that was one of the real incentives for us.
That's fantastic. There was a question for Serene and Amy in the chat, but it seems like it's already been answered. If that Cindy was asking if that was 700 childcare centres in the dashboard, and I think you've confirmed, Serene, that that was the case. That is a really large number. Was that was it hard to get that many centres on board? It seems like a really big number. Yeah.
I can speak generally, but I think Amy will feel the pain much more than me. So I will say they were a group of childcare centres that we had existing contact with. They had already given us permission to call them again. So we're starting, I guess, with a softer lead. But I'll let Amy kind of speak to that as well.
Yes, there was a lot. We did have a panel, and they were a bit more engaged than I think if you were to be just approaching people who hadn't participated before. However, there was a lot of follow-up. So we did send an online survey, an email, and then there was a number of telephone call follow-ups where our interviewers, they're really engaged with the services, and particularly some of our interviewers who have worked with services before. So they were able to build that rapport and work with them in terms of when it was feasible for them to complete the survey. If they wanted to do it over the phone, they do it over the phone with them. So just that flexibility and just, building that relationship, I guess, with them to try to get them to get over the line. So,
Yeah.
lots of credit to the project team.
Sounds like those relationships are really valuable. There's another question for you both from Nadia in the chat, and it's actually similar to something I was wondering about the dashboard and how it's sort of utilised by the stakeholders. So the question is, can you speak a little more about feedback from the childcare stakeholders involved, particularly their thoughts on likely sustainability of continued involvement in providing data, and also the impact of the data dashboard in improving their implementation of nutrition and physical activity strategies?
Yeah, so I think initially we had started off with a very state-specific approach. So working with New South Wales, which many of you know has like health promotion teams sitting within local health districts. And as part of, I guess, their work, they do have an online information collection system that looks at, I guess, munch and move practices, so kind of implementation of some of the nutrition and physical activity indicators that we also looked at. I think we simplistically thought, an additional barriers assessment to that dashboard could be, I guess, one way of making it a bit more routine. I think we had to go through the process of how to make understanding barriers score a bit more palatable, how to detect when a change in barriers is observed, which was all the yellow lines, because you'd expect normal fluctuation, but when something fluctuates a lot more than that would trigger an action. Otherwise, you would just kind of expect it to track along. So that was, I guess, the initial thought. Since then, we have, as you can see, collected data nationally. I've spoken to, I guess, the others on our CI team who represent a number of other states in terms of, I guess, who would find this most useful. I think some of the suggestions were to speak with like accreditation agencies. So in early childhood, there is a CEQA and Department of Education accreditation officers that do visit childcare centres to be able to populate some of this data. The other suggestion is kind of applying this type of concept to education data that is routinely collected, education data, well-being data, that is already kind of probably being collected but not populated in this way. So that, I guess, was a very long-winded answer. We've been thinking about it. So if anyone wants to send us some thoughts, we'd love that. Amy, did you want to add? Oh, sorry, if we've got time. I don't know if Amy, you wanted to add. No, yeah.
That's great, thank you. So I've got a question for Sarah and Ashleigh before there's another question for Sherridan in the chat. But I was wondering, with your tobacco communications research, that you found that there was no difference in the messaging condition, which was not what you expected, but other circumstances, like the types of products that they were using and the attention to already quit, were sort of like predictive factors. Is that something that was expected, and is that something that's consistent with existing evidence, or was that something that you also weren't sure that you would find?
I mean, Sarah can sort of jump in and correct me if she has other thoughts, but I don't think that was entirely unexpected. I think from previous research, we do know that people who exclusively use one product, that is predictive of quit intentions. And the other one being that they were already planning to quit, already sort of thinking about quitting in the next 6 months, for example. Those people were also more likely to report to quit, intending to quit in response to the bans. That also is not entirely unexpected, because I think sort of logically we think maybe the bans is just, it's just another trigger, another reason why it's a good idea to quit. And I think that sort of speaks to sort of policy options in general, that it's about sort of a suite of policy changes and a suite of reasons and facilitators for people to quit smoking. That's the question. Sarah, anything else to add?
Yeah, I suppose the other thing just to note is that we did get some change on the menthol specific messaging according to those different conditions, where the extra information was useful in terms of creating more accurate perceptions of the harms of the remaining products, the non-menthol products. So I think that's really useful. And I think also the case with all communications is you need repeated exposure really to get people kind of along that behaviour change trajectory towards, you know, being more likely to quit. So potentially that was part of the reason we didn't see those effects on intentions to quit was because it was a brief exposure to the message, and perhaps repeated exposure we might have got more indication of that for those menthol products specifically, where we did get an indication of more accurate perceptions, kind of more the upstream factors having effect of more of that information being provided to people. So I think, you know, the findings really do indicate to me that we do need to have that extra information, especially around that menthol ban that's likely to be implemented, and it's going to be really important that we emphasise the harmfulness of the remaining products on the market and the reasons for the ban as well. So, yeah.
Yeah, thank you. I'm sure that information will be vital to the government as they're looking to implement that and how they're sort of going to roll that out in the future. So there's a question for Sherridan from Linda Davies. In New South Wales, the Ministry of Health liaises with large retailers like Coca-Cola, Zuki. Is there potential to work across states on this food retail policy and large retailers like there has been for school canteens? So what are your thoughts? That's probably for Sherridan or for Shaan. I know you're both working across that. So
I think it's a really good point, because now that almost every state has their own food and drink supply strategy and working in similar settings, the large retailers, I've noticed, particularly in the last year, are starting to cotton on to that and the differences between the states. We've had some come to us and say, oh, you know, this is classified as this in Vic or New South Wales and it's this in Queensland, what's going on, which is great because it means that they're noticing that these initiatives are in play, but we're always looking for consistencies. And I think engaging with suppliers and large retailers is a particularly important part of the process, and kind of making change across the whole system, not just relying on the health practitioners in healthcare or tuck shops or sporting facilities, and kind of having that support from the people producing and supplying the food. So it's a key component of our way forward and our kind of comms plan to be able to engage with these types of suppliers. We're not really sure how we're going to do that yet. So Linda, if you want to chat offline and talk about strategies there, I'm more than happy to do that, because yeah, we can absolutely do more together.
that's great, and building good connections there. A number of you are working on projects in partnership, and I think you presented some similar challenges in terms of, you know, how to maintain buy-in and interest from the various stakeholders that you're working with. And it seems like there's a lot of lessons to be learnt collectively there as well. So we are on 3:30, so I don't want to run over time because I know everybody's very, very busy. I'm sorry that we didn't get to have some more time for Q&A. I actually have a lot more questions that I wanted to ask all of you. But thank you so much for presenting this fantastic research that you've all been undertaking. It's really, really new and innovative, and it's great to see where it's all progressing. So thank you so much for your time today. Thanks for everybody for joining. And yeah, so enjoy the rest of your year. We'll wrap up for the afternoon. And yeah, have a nice time. Thanks again, everybody.
Thank you.
Thanks, Maddie. Bye.